Whoa. If not, I'll be in next. There we go. Are we ready? You're good. Ready to go? All right, thank you everyone for your patience. We've been given the green light. The first presentation that we will be having is an analysis of refugee resettlement and rural health diversity patterns and health needs across New York State. Our presenters are Julia Vinagulu-Bauer. She is a Health Program Coordinator 1. And the second presenter is Amanda Vasilovich. She's a Senior Health Program Coordinator, both from the New York State Office of Minority Health. Thank you.
All right, all set? Yeah. All right, good afternoon, everyone. We're looking forward to sharing our analysis of refugee resettlement and rural diversity patterns on health needs across New York State. Thank you, Wilma, for the introduction. We also wanted to thank Wilma for, thank you for all of your support and guidance and oversight with this project. As Wilma mentioned, my name is Julia Vinagulu-Bauer. I'm a health program coordinator here at OMH HTP. My pronouns are she, her, hers, and I'll just pass it over to Amanda for an intro.
Thanks, Julia. My name is Amanda Vasilovich. I'm a Senior Health Program Coordinator here at the Office of Minority Health and Health Disparities Prevention, and we will get into our presentation.
Thank you. So just a disclaimer, this presentation was supported by funds made available by the CDC COVID-19 Health Disparities Grant, national initiative to address health disparities in populations high at risk and underserved. Throughout this slide deck, racial and ethnic groups are referred to by the current federal standards as known by the authors. So, throughout our analysis, we interviewed subject matter experts in both fields. This includes rural health and refugee health experts. We analyzed rural diversity data, reviewed refugee resettlement patterns, and summarized key health needs and priorities in rural areas with changing demographics. With regards to rural diversity data, we analyzed demographic data for 44 rural counties across New York State, using 5-year public data from the American Community Survey. With regards to refugee resettlement patterns, we conducted a literature review and utilized publicly available data from the New York State Refugee Health Program. We also conducted interviews with refugee and rural subject matter experts to gain perspectives on top health priorities. In interviewing subject matter experts, we delved into the different definitions of rural, starting with the federal definition, which varies across the United States Department of Agriculture, the Office of Management and Budget, Health Research Services Administration, HRSA, and based on population density, census tracts, distance to metropolitan areas, and zip code, these definitions vary pretty widely. According to the New York State definition of rural counties, that's any county with a population of less than 200,000 individuals. According to the New York State definition, which is based on the census definition, 44 out of 62 counties, or 71%, are rural. In interviewing subject matter experts, we delved into some key rural barriers that we were able to learn more about. One is limited transportation due to limited public transport, lack of rideshare services, and geographic barriers. Another was limited access to grocery stores and healthy foods. We noticed that in a lot of communities, individuals had to go to gas stations in rural communities just to gain, to be able to purchase fruit, fresh fruit. Limited technology access and health literacy was also a common concern due to broadband access and lack of smartphone use. Lack of providers due to kind of hinting at the workforce shortage, which we'll get into later, lack of linguistic resources, and lack of resources that support and supports that urban areas have. In interviewing subject matter experts, a common sentiment was the sentiment that no one's coming to save us due to resources and funding, which are often directed to urban areas and priority populations, which leave rural communities out. As a result, this often leads to a lack of trust for government agencies. A summary of rural demographics from our subject matter interviews includes the fact that the majority of residents are white, there's a lot of migrant farm workers, Amish and Mennonite populations, growing refugee populations. 15 to 20% of LGBTQ+ people live in rural America, and there's a greater proportion of older adults and individuals with disabilities, in addition to lower formal education levels. Results from the 2020 census show growing diversity in rural America. Immigrants constitute 1/5 of population growth in rural areas in the United States. There's a growing presence of Latinos in upstate New York, and population loss is greater in rural counties than in urban counties in New York. According to our analysis of American Community Survey data from 2012 to 2022, across the top 5 rural counties, which we identified as the top 5 rural counties with the most change or increase in diversity, these are Putnam, Schenectady, Sullivan, Tompkins, and Ulster counties. As you can see, there's an increase in diversity, in particular those who identify as 2 or more races, some other race alone, or Hispanic or Latino, in addition to Asian alone and Black or African American alone. You can also see that there's a decline in those who identify as white alone, not Hispanic or Latino, with a decrease of 6.6%. As we think about key health needs, it's also important to consider age. The aging population is increasing in rural areas, with an increase of about 35% of individuals over 65 years. Now I'm going to go ahead and pass it over to Amanda to discuss refugee resettlement patterns.
Thanks, Julia. So kind of keeping in mind everything that we've been discussing so far with the rural areas, we started to obviously see the increase in diversity, and we just wanted to consider how this could potentially overlap with the refugee community. So we did a bit of a literature review on what the refugee landscape looked like across New York State. So just some quick facts: 50,000 or more refugees have been resettled throughout upstate New York since 2002. Buffalo, Syracuse, and Rochester are in the top 50 areas nationally for refugee resettlement. And then an example of how this sort of changes the landscape of cities and areas when refugees are able to come into the area. So Utica is a good example of this. Since 1981, Utica resettled over 16,500 refugees from more than 30 different nations. And then that reflects in today's population, with 20% of Utica's population being foreign-born residents and speaking over 40 languages. Also in our literature review, we took kind of that like broader bird's eye view to look at the way that migrant populations have played into the rural sort of landscape of things. So migrants play a pivotal role in the agricultural economy in upstate New York. And then there's the sort of health disparities side of things, where folks are often facing cultural and linguistic barriers due to unmet language access and health literacy needs. And that's sort of where this overlap has come in, and why we're looking into this very specific area of the rural health needs. So this is a geomap we created based on data from the Office of Temporary Disability Assistance, and they're the ones who fund the Refugee Health Program, which some of the later data is from. This illustrates that a lot of the service providers are located in urban areas, and some of the top areas, which are the yellow circles, they are New York City, Buffalo, and Syracuse. So that's where the majority of the providers are. And then the blue circles, there's lesser providers for the refugee program. In this graph, we illustrated how there's different counties, or the top 5 counties for refugee arrivals between 2012 and 2022 in New York State. So those counties are Erie, Onondaga, Monroe, Albany, and Oneida. And you'll see there's obviously some major spikes and then a sharp decline. And so we'll notice that around 2016, there was a big increase in refugee arrivals, and then a sharp decrease between 2016 and 2020 due to federal changes. And then in 2020, obviously COVID happened and has impacted the ability for refugees to come in through different programs. So some challenges for refugees resettling into rural areas. Obviously, the refugee service providers are mostly in the urban areas. So when refugees come in through New York State programs, those service providers are the ones that do their initial screening and provide them with assistance that's through New York State. So if they're all majority in the urban areas, leaving those areas is going to be a little bit more difficult. Rural areas may offer more housing options in terms of physical space, but that doesn't mean that there's necessarily resources to back it up, and it might not be accessible for refugees. So when Julia was kind of going over all of those issues that are happening within the rural landscape for all folks that are already there, if we consider, refugees in this case, but additionally new Americans, we want to make sure that we're not contributing to the health disparities and we're supporting the communities that we're bringing in. So some of the limitations on the rural data, so the graphs that Julia presented, the data sets aren't perfectly comparable due to variations in geographic boundaries, population controls, and different improvements to race and ethnicity questions between the American Community Survey years, as well as population shifts between age groups that's been caused by a variation in birth rates. So an example of this is that the baby boomer population is larger than other generations. Some limitations from the refugee data perspective is that, again, this was just the refugee health program, so it's not representative of all immigrant, migrant, and undocumented populations. And then trends in racial and ethnic diversity in rural areas is not fully tied to refugee resettlement, but it is something that we should consider as we're looking at increased diversity, as well as there are refugees that do identify as white, so we can't always say that that is specifically tied to diversity in terms of race and ethnicity. So some suggestions we have for future research is an assessment of healthcare workforce diversity data. I mean, it would be great across the state, but specifically for this project in the rural areas, making sure that the population that we are serving, we're also representing in our workforce. An assessment of language access support in our rural communities. So as they become more diverse, are our needs also meeting those of the community? And then analyze data of all new arrivals, not just refugees. Those are our sources that we used. And then we just want to give a special thanks to former coworker Rebecca Pendergrass for her analysis on the rural data, and then Carly Marone for her assistance with identifying trends with the refugee resettlement patterns. And thank you so much for all of your time. We really appreciate it. We're looking forward to hearing everybody else's presentation as well.
Thank you. One of those statistics just jumped out at me, like what is considered rural, the percentage? Anyway, our next presenters will be, their presentation is towards a framework for addressing issues and implementing solutions for culturally and linguistically diverse, CALD, communities within healthcare systems. We have Professor Janed Altariba and Associate Professor Rukshana Ahmed, both from the University at Albany SUNY. Thank you.
Good afternoon, everyone, and thank you for being here. The just prior presentation really sets us up well because they mentioned culture and language as being a particular barrier for us. I am pleased to be joined by Dr. Roxana Ahmed, and also part of our research team is Dr. Dina Refugee, who spearheaded today's conference. So first we'll hear from Roxana to sort of set up the situation that we're going to be looking at in terms of New York State and provide some statistics, and then I'll talk about a study that we actually did looking at culture and language as potential barriers for immigrants. So Roxana.
Thank you, Jeanette. Good afternoon, everyone. So as Jeanette said, I'm going to set the stage here and just going to highlight some of the statistics. And we do have a disclaimer that they are from the year 2018. They're published, but we are certainly, the evidence from the literature did inform the study results that Jeanette is going to present in a while. So as you can see, in 2018, the foreign-born population was estimated at almost 23% of NY State's population, and approximately 3.6 million of the state's population were native-born with at least one immigrant parent. And as you can see from the bar chart there, which is presenting foreign-born New Yorkers by gender and race, we don't see much of a gender gap there, but in a few slides, we will look at some interesting stats. So as far as the profile of foreign-born New Yorkers continue, according to the American Community Survey 2018, almost 76% of foreign-born New Yorkers were between the ages of 18 to 64, which was considered of working age. So let's dig a little deeper into language as an identity marker. So according to the ACS survey, in 2018, more than 45% of the foreign-born population reported speaking English less than very well. And these LB New Yorkers made up almost 37% of naturalized citizens and 57% of non-naturalized citizens. So as we know that language can be an enormous structural barrier, because LB New Yorkers are more likely to be having less formal education, and then likely to live in poverty, likely to be of working age, as we have seen, but having lower labor force participation than their English counterparts, English proficient counterparts. And if you remember, I was referring to the gender gap. So even within the LP population, males' labor force participation was sitting at 75%, while the LP females' labor force participation was sitting at 49%. So this is just a table format of some of the stats that we presented. So I'm going to skip this and go to this slide to talk a little bit about some of the social determinants of health that can disproportionately affect LP populations, and also talking about the immigration experience, which can also be an adverse social determinant of health in itself. So we have witnessed from the COVID-19 that the crisis, the pandemic, inflicted disproportionate harms on LP communities, CALL communities, from poorer health and education outcomes to higher unemployment. So we can naturally ask, what are the structural causes for health disparities in these communities? And as I mentioned at the beginning of the presentation, we're just gonna shine some light on language as a structural barrier. So limited English proficiency can lead to, as we have seen, low health and digital literacy, have people live more in poverty, although they can be of working age, but they cannot participate in the labor force at a low, and then they can participate at in the labor force at a lower rate than their English proficient counterparts. They lack health insurance, have inadequate access to linguistically and culturally appropriate services, and can have limited or no access to public assistance. So, even though we are into the post-pandemic times, we see that these times continue to have significant impacts on social determinants of health for these communities, bearing a disproportionate burden of the crisis and also the related crises that we are seeing right now. The immigration experience often serves as an additional social determinant of health, what we have documented in the literature. This could lead to lack of access to systems that effectively address linguistic isolation, low language proficiency, separation from systems of support, lack of sufficient access to educational resources, low health literacy, and effective access to culturally and linguistically competent services. And these are structural barriers to positive health outcomes. So in a little while, Jeanette is going to dig deeper into some of the, in the next two parts, some of these structural barriers and also talk about the approaches. But before ending the first part, I'd like to bring your attention to some of the ways we can reduce the health disparities for these immigrant communities, CALL communities, LP communities, by mandating changing the structural conditions where people live, and also by using social, economic, and political drivers that can shape positive health behavior and reinforce protective factors in these communities. So Jeanette, the floor is yours. Thank you.
Thank you, Roxana, for setting the stage. Okay, so it's good that she mentioned COVID, because some of the work that I'm about to share with you was work that we embarked on actually during COVID. And it's interesting because while we know all of the consequences, mostly negative, that happened during that period of time, if we want to say there's one somewhat of a silver lining, is the notion that going through that and those processes that we're still being affected by today actually made it very, very clear that some of the services we provide need to take into account culture and language. And we could see that throughout all of what happened at COVID, particularly when it came to trying to have individuals consider vaccines, trying to have them enter the healthcare system. It really did emphasize and highlight the fact that we had a long way to go in these areas. Now, my focus now is on the healthcare system, but some of the things and some of the comments I'm about to make can probably be translated to a number of other institutions and organizations and not simply healthcare. So whether that migration was voluntary, whether we're talking about immigration or the term forced mobility, sometimes people have to leave for a particular reason or they perceive that they need to leave. The general issue in some cases is that there's no access to help in an individual's first language. So that's a real barrier when someone immigrates to particular areas, and this could have impacts on psychological services or also those for physical health services and physical support in general. There's now such a body of evidence, and these are just some general conclusions as to what are some of the consequences, negative consequences associated with poor communication or the fact that culture and language does not line up with the providers in these areas. The lack of access to preventive care, delays and misunderstanding of treatment. The misunderstanding of treatment, together with errors in diagnoses and poor decision-making, are very often related to either cultural factors or linguistic factors. So to give you an example, an individual who, for whom English is not their first language, is very limited English, begins to talk about how they feel or some of their symptoms, and this is translated to depression, where it may be the case that they just have difficulty articulating in that second language, and that might be the only language that the provider knows. So that might lead to these diagnoses of depression or anxiety, or which in fact are not accurate, but it's really something that there's an issue with communication. All of these things and many more, the kinds of consequences, the kinds of struggles and challenges for individuals where their language and or culture doesn't match that of the situation in which they're being treated. Now, my background is actually as a cognitive psychologist, and I study bilingualism primarily and the representation of emotion. So it's very clear through that literature that how people process information in L1 or their first language is very different than L2. Many of these types of areas actually have a very strong emotional component. And it turns out that in our cognitive research, we've indicated or we've examined the notion that L1 for many people is the more emotional language, and L2 is less emotional. So you learn your emotional content and references and so on in your native language, in that first language, and that first language is the one that might be more emotional, so treatment in that language might be more helpful. It's clear that there's a strong relationship between language and culture. It's through language that we actually talk about our ideas and beliefs and attitudes and all of our worldviews. If you can't communicate in that language, you're also not communicating some of the cultural implications or cultural ways of thinking that could lead to better and positive outcomes with regards to health. In fact, there is a whole list of studies and research that's examining what happens when there's a match or a mismatch in terms of culture and language and the provider that people are working with. And it might be an increasing utilization of services and positive outcomes to make a match in some situations, at least to be treated by someone that has some familiarity with a background or some experiences. So we know that culture then, having that understanding and respect for beliefs, what's a taboo, what's a superstition, how do people think about and practice in terms of religion and health, and valuing bilingualism as an individual's strength, all of these things are very important, and being able to understand verbal and nonverbal behavior. So it leads us to a discussion of these class standards, culturally and linguistically appropriate standards. And released from Health and Human Services, particularly the Office of Minority Health, these describe a framework, an actual framework to talk about the delivery of services that are culturally and linguistically appropriate, respectful, looking at cultural health beliefs and communication. The interesting notion is that these are federal guidelines, but you can enter many different institutions, as we have locally and talked about nationally, where these standards, either people are not aware of them or they're not being followed and enforced. I won't go through this slide with any level of detail, but if you looked up these class standards, I'm sure many of you are familiar with them. They range from the institution itself to what should happen with human resources and staffing, what happens as an organization, what happens at the level of the patient, what happens on an individual level. They're a set of guidelines. And in fact, some of these guidelines must be in place if an organization or institution is receiving federal funding. And we know and we have documented locations where these things are not being followed. So the question, how do you systematize or include in your organization or structure or in your healthcare division the notions of culturally and linguistically appropriate services? How do you sort of enforce that? This is a citation for a paper that we published a couple of minutes. And very quickly, we surveyed a number of frontline healthcare and social service providers, and this happened in 2020. So this was really good timing with the pandemic. We had over 200 responses, and very interestingly, some of our data was collected from individuals who are on a listserv that's part of the Society of Refugee Providers. And so these are individuals, and this was cross-sectional and across the country. So states including Oregon, Minnesota, Nevada, and North Carolina, spanning the US, we had respondents, individuals who were providers and directly worked with refugee and immigrant families. Some of the things they noted to us are included in this table. Our publication includes much more, really trying to identify what are those areas that are included with culture and language that pose barriers or difficulties for immigrants or refugees or new Americans, as we would call them as well. Is the healthcare system responsive? Do they even understand preventative medicine? And in many cultures, that's not a typical thing to understand. Some of the comments we received in our surveys, and we also conducted focus groups, so we did a qualitative study, and that's the work that we provided, even said the concept of refilling a prescription or having a chronic condition where you need to be treated probably for the rest of your life. Some of those concepts are very difficult to understand, may not actually be part of the culture, of the original culture of the individual. So to conclude, some policy and practice recommendations. We would advocate, and the research would indicate, a strengthening of, in fact, the enforcement, the accountability of the use of these class standards across a number of institutions and organizations, integrating healthcare with other systems of social services so that there should be more networking across the various areas of social service that an individual would have in a community or a town or a city. That coordination we find is sometimes missing as well. And training, a kind of training in immigrant and refugee health for providers. And we would also say we need more trained professionals who also represent a diversity of background and culture and language. This is a real important issue. How many folks are like us doing the research or being in the communities? Evaluating through key metrics and increasing transparency by issuing regular updates. Again, the accountability. It's not enough for, we know that these things exist, but are we being accountable? Thank you very much.
Thank you very much. Yes, we're seeing here a disconnect between policy and practice. So I look forward to the discussion after this. All right, our next presenters their presentation is undocumented immigrants and their healthcare policy in the United States, Canada, and Germany. And we'll be hearing from Abdullah Al-Hilal, a research assistant from the School of Social Work. Yay, social welfare, from Morgan State University, and also a fellow presenter who will be coming up. Thank you. Is also presenting with you?
Oh,
No? Okay.
so this one, please.
That's the green, this green one.
Okay, and go and forth, back.
Yeah, back and forth here. Try this one.
This is back.
Yeah.
Okay. Okay. Good afternoon, all. It's my pleasure being here and meeting with the nice people. I'm Abdullah Al-Hilal, graduate research assistant, and at the same time, I'm a PhD student at Morgan State University, Baltimore, Maryland. So the paper we are going to present, this paper is authored by me and my professor, Lawrence Mann Slatman, Assistant Dean and Professor, School of Social Work. On behalf of our team, I am going to present this paper. So as you already know that our topic is healthcare policy for undocumented immigrants in United States, Canada, and Germany. So I would like to make sure that our topic is not particularly relevant to new work. So it's a broader aspect regarding the healthcare policy for undocumented immigrants, particularly United States, Canada, and Germany. Well, so undocumented immigrants over the past decades, they have been increased across the world, estimated 30 to 40 millions. They have been crucial to economic prospect and prosperity. Several studies have documented that undocumented immigrants contribute to 150 billion yearly worldwide remittance that make them highly internationally relevant. Apart from them, they pay tax, contribute in both financial and non-financial ways to community. Some start business and perform integrated role in agriculture, hospitals, industry, vital to economy. But due to their immigration status, they discovered themselves vulnerable to their host countries and are restricted from accessing to health service.
The green is for the next slide.
It's not working.
No, hold on one sec.
Okay. Okay, so the objectives of our paper is to explore the impact of political ideologies on healthcare policies affecting undocumented immigrants in United States, Germany, and Canada, with a detailed examination of health status and health service of this population in these countries. And regarding the methodology, though it is secondary analysis, but this study investigates the definitions and the ideological underpinnings of policy towards the undocumented immigrants with a broader understanding, contributing to a broader understanding of policy impacts on this vulnerable population. So, first of all, the conceptual definition of undocumented immigrants. As you know that undocumented immigrants literally refers to the population who live in host countries without the legal documents. However, the GREO has identified several types of undocumented immigrants. For example, those people enter a country with valid documents but stay longer than their document permits, like overstay. So they are undocumented. Another is like the people freed from deportation centers because they cannot be deported. And another type of undocumented immigrants is like the people have lost their residency and jobs and they cannot renew it. And another types of undocumented immigrants are like the people are stateless and they have had difficult complication to collect the official documents. And also undocumented immigrants are those who have entered the country through trafficking and smuggling, as well as some asylum seekers who are like exhausted in asylum procedures and eluded arresting and deportation. So our paper has identified as I have already mentioned, that the health status of undocumented immigrants, and our paper figured it out that every year, thousands of undocumented immigrants enter in United States, bearing the unproportionate number of illness that including communicable disease like HIV and tuberculosis diseases. And undocumented study has also found that undocumented immigrants have, they report lower level of heart diseases and the other diseases. Several studies have documented that the undocumented immigrants are less likely to visit hospitals or doctors because they cannot afford it, because it is expensive for them. And another thing is that the fear of deportation. However, on a large scale, the undocumented immigrants are exposed to negative social determinants of health, and like the poor living and working condition impact their health badly. And our studies has also found that the worsened mental health is very frequent and common concern for them, that put them at higher risk for post-stress syndrome and the substance disorder. And another studies have documented that 3 diseases are very common among the undocumented immigrants. One is post-traumatic stress disorder, tuberculosis disease, and cardiovascular diseases. So 3 diseases, that means our undocumented immigrants are high risk for these 3 diseases. And our studies have also found that undocumented immigrants, undocumented status is associated with the cause that produce poor health outcome among the undocumented immigrants compared to their documented counterparts. And also undocumented immigrants have the clear social and economic disadvantage that are greater risk for them, for undocumented immigrants. And also undocumented immigrants takes the emotional tolls that impact their overall health and well-being. And this is our key findings. We have compared the healthcare policy in 3 countries, United States, Germany, and Canada. And we have find out the number of undocumented immigrants. We have mentioned the benefits they are entitled to. And another thing here, I need to mention here that the United States, evidence confirms that United States is the only one wealthy and industrial countries that does not offer universal health care. And here we can see that political ideologies considerably different among the East Partition coalition. For example, in United States, Democrats are very supportive to the immigrants, but conservatives, they support the restrictive policies for the immigrants, but Democrats are less restricted to the immigrants. So it's similarly like in Germany, the far-right populist alternative for Germany, it's the mainstream party of Germany, they have just zero tolerance for immigrants. But the Christian Democratic Union, they are very supportive for the immigrants. And similarly in Canada, conservative policy of Canada, they support the very restrictive policy for immigrants. On the other hand, New Democratic Party and Green Party, they support less restrictive policy for immigrants. So our study has concluded that this political ideology impacts the healthcare policy for undocumented immigrants. Like United States, the undocumented immigrants are barred from the healthcare service, like Medicare, Medicaid, CHIP. So policy implication, since we have the social work background, I am the student of social background and my professor is from social work, so we have suggested the policy from the social work, knowledge, education and policy. So social workers can educate the immigrants community about their legal rights and help navigate the laws that impacts their health, well-being and service utilization. And service, supportive service workers, that means social workers, can be vital for promoting the health of undocumented immigrants because they can give the information and the referral to the immigrant clients that is associated with their service. And more importantly, the immigrant social work can be involved in legislation process. In this process, they can influence to reform the policies that will have the options for providing services to undocumented immigrants. And this initiative can involve lobbying for policy change, empowering immigrants' voice, legal support, and also leveraging the influence of professional social workers organization to endorse and to support the pro-immigrant policies. And finally, social workers should coordinate community-based service and form coalitions to respond to the critical impact of current welfare reform legislation and undocumented immigrants. And in this regard, it is worth mentioning about the interest convergence. It is a key concept of race policy, critical race policy, and the Bell in 1980, who coined this. So according to the interest convergence, there will be no racial progress until the interest of this marginalized population are aligned with the interest of those who in power. So we have to align the interest of marginalized people with those who are in power. So finally, here our conference main theme is immigration integrate. And we know that we need to integrate immigrants in order to build a community what is economically strong and inclusive culturally and socially. So if we want to build a economically strong and culturally and socially inclusive society, we need to integrate the immigrants, including the undocumented immigrants. And access to healthcare for undocumented immigrants can be a critical step and a very significant step to integrate undocumented immigrants. Thank you so much. Thank you for hearing me.
All right, gives us a bit to ponder. All right, so our next presentation is Seeking Help. Let me see if I can advance this slide. No, there we go. Oh, there you are, all right. Our next presentation, Seeking Help, Finding Hope, Addressing Mental Health Disparities in Asian Populations. Andrew Santa Ana, Deputy Director of Research, Asian American Federation, and Dean Lee, Research Analyst, Asian American Federation. Welcome.
Right. Good afternoon, everybody. Awesome. Thank you for coming out on this beautiful Wednesday in Albany. As mentioned, my name is Andrew Santa Ana, and I'm the Deputy Director of Research and Policy at the Asian American Federation. And I am here today, let's see if this works. Which, is it just the advancement? Perfect. Okay, and I'm here to talk about our recent report, Seeking Help, Finding Hope. For those of you who don't know, at the Asian American Federation, we raise the influence and well-being of the Pan-Asian community through research, policy, advocacy, public awareness, and nonprofit support. I'm presenting today the fantastic research of our team led by Dr. Lin Ying He and our research team, Dina Lee and Yuncheng Wang. They're actually joining us virtually, so I wanted to make sure that I gave them a shout out. Okay, so Asian Americans are among the fastest growing demographic in the United States and New York. But when it comes to mental health, they haven't gotten the spotlight they need. They don't tend to use mental health services as much as other ethnic groups. And that means we don't know as much about what they need or the hurdles that they're facing. It might look like they don't need help, but that's not the case. The rise in hate crimes and being treated unfairly, especially with COVID-19 in the picture, has really shown the tough mental health issues they're dealing with, which we didn't see before. And that's why the Asian American Federation has been digging deep, doing this research to fill in the gaps about this community's need of mental health care. So, for this report, our objectives were to dig into the mental health challenges faced by Asian New Yorkers, shed light on the hurdles they encounter in getting help, and suggest ways to build a stronger support network for their mental well-being. So, our methodology, marking the first initiative of its kind, we collaborated with 15 community-based organizations to conduct a survey with 543 Asian New Yorkers representing 23 distinct ethnic groups through questionnaires available in 11 different languages. We also teamed up with 5 of these organizations to run 6 in-person focus groups. A diverse mix of 46 participants from different Asian ethnic communities joined these conversations, offering us a wealth of perspectives from across New York City. And today, I'm really delighted to share some of the findings of our report. According to our survey, 65% of participants indicated that they experience feelings of isolation or anxiety to some extent, with almost 40% describing these emotions as somewhat strong or very strong. Over half of participants reported that their feelings of isolation or anxiety had gotten worse since the pandemic. Among those, 34% identified anti-Asian hate crimes as the main cause. It's a common misconception that Asian Americans are financially well off. But that's not the case, especially with the high cost of living in New York City. In reality, a third of Asian Americans in the city are low income. And our survey findings show that 44% of respondents cited New York City's high cost of living as the top reason for their feelings of isolation and anxiety. And the steep cost of living in the city can not only trigger new mental health issues or worsen existing ones, but it also creates a barrier to seeking mental health services. According to our survey, 30% of those who are stressed about living costs stated the financial constraints as the main reason they didn't get mental health support. The urgent need to cover expenses often overshadows the need for mental health care, setting the stage for more serious mental health problems. Seeking mental health treatment and services first requires recognizing the features of mental health issues, which in many Asian cultures is a concept that simply does not exist. Instead, these issues may be more readily perceived by their physical symptoms among the Asian community. So, in our survey, 80% of participants reported experiencing symptoms usually associated with mental distress, including persistent fatigue, insomnia, heart palpitations, headaches, and a lack of appetite. However, only 45% of these respondents expressed a desire for mental health report. This discrepancy suggests that Asian Americans may be more comfortable addressing the physical symptoms than acknowledging and seeking help for mental health issues. So, when we did our research, we found that here are some of the top barriers that prevent Asian New Yorkers from accessing mental health support. The survey revealed that 34% cited a lack of information or straight up misinformation. 33% cited language access barriers, and 29% mentioned cultural barriers as significant obstacles to accessing mental health services, a theme we had already heard about today. Almost half of Asian Americans in New York City have limited English proficiency, so it makes it very difficult for them to find good mental health support from communities and folks that speak their language. And even for those who speak English well, talking about mental health can be difficult due to cultural differences. People have mentioned that some details of their mental health struggles are missed by those who don't understand their culture deeply. Following the lack of information, language, and cultural barriers, over 21% of survey participants identified fear of judgment as a key reason for not seeking mental health treatment. In Asian American communities, there's a big worry about mental health stigma, like it's a sign of weakness or could shame the family. So, a lot of folks don't get help until things get really bad. And it is not just among older populations. We found that younger ones often feel that they have to tough it out alone, which can make things worse. So, I'm going to turn to our recommendations. While we acknowledge that the broader need to make mental health services more affordable and reduce the difficulty of exploring insurance options, this report focuses on specific recommendations tailored to the distinct challenges that Asian communities experience, including expanding mental health education, investing in in-language and culturally competent providers, and partnering with community-based organizations. As mentioned in the discussion of mental health access barriers, many Asian Americans do not seek help in the first place because they lack knowledge about the causes of and treatment for mental health issues. So our first recommendation is expanding mental health education, because providing materials and programs that really speak to Asian American experiences and values can help big time with mental health awareness. They can break down the stigma by talking about what mental health issues look like, the signs to watch out for, and where to get help. Our survey shows that when it comes to mental health, folks often turn to their friends and family for help. By sharing personal stories of overcoming mental health hurdles, we can start more chats and dialogue about it and make it a normal part of the conversation. Also, over a third of these people we talked to said they asked their family doctor about mental health issues. This tells us that we've got to get mental health on the radar of regular doctors, so it's part of the healthcare mix just like anything else. And it is important that with healthcare providers to expand educational programs and materials that are geared to people to recognize that mental illness is a legitimate issue, similar to conditions like asthma and diabetes, with effective treatment available. They must encourage the notion that seeking help for mental health concerns is a demonstration of strength rather than a sign of weakness. Over half of the people we surveyed prefer mental health services that offer support in their own language and those who understand their cultural context. This aligns with our second recommendation of increasing the number of Asian American mental health experts who provide culturally sensitive care. Rather than simply pairing patients with therapists based on ethnicity alone, this includes recognizing Asian family dynamics, their implicit communication styles, and preference of action-oriented approaches. So, for example, often older members of the Asian American community might show signs of mental distress through physical symptoms due to cultural beliefs and stigma. Talking about physical ailments like fatigue or discomfort may be more socially acceptable for them than expressing emotional struggles. Asking about basic things like sleep or appetite can be a helpful way to start a meaningful dialogue about mental health. One of the things I'm really proud that the Asian American Federation has produced to address this is to create a directory of mental health resources. So to support Asian New Yorkers finding culturally relevant mental health and providers to fit their needs, whether this means counseling, education, or other diverse ways that Asian communities use to seek mental health well-being. Last year, the Asian American Federation rolled out a groundbreaking mental health directory that features hundreds of providers who collectively speak over 17 Asian languages. So as you can see here, we have, you can search it on our website to find out more. Our last recommendation highlights the importance of collaborating with community-based organizations, because these organizations really get what's going on with Asian American neighborhoods. They know how to blend the traditional ways with today's mental health care. Trust people because they speak the same language, literacy, and culturally, because that's super important when it's difficult to talk about mental health issues. What we found is that a good chunk of folks, about 1 in 4, go to these local places when they need to find help or info on mental health. These groups know how to make their help fit just right for the people that are looking out for support. So, plus, nearly half of the people we talk to are all for support groups that these local organizations run. They're popular because they help people feel understood and safe, and that's key for good mental health. And it doesn't matter if it's face-to-face or online. These groups work wonders either way. Okay, so through this report, I actually just wanted to send a heartfelt thanks to all of the community-based organizations. There were 15 who collaborated with us on this report. And I definitely wanted to give a shout out to the Korean American Community Foundation because of their generous support who made this possible. Thank you very much.
Thank you very much for your presentation. And I'm looking forward to the questions, so let's, start thinking about them. All right. Our last but not least presentation is Our Child, a web-based application to address childhood mental health disparities by providing accessible, linguistically and culturally tailored mental health information to Chinese parents. Our presenter is Yena Song, a postdoctoral research fellow, Section for Health Equity at NYU Grossman School of Medicine at NYU.
Hello, everyone. Can you see my slides and hear me well?
Hold on just 1 second.
Okay.
Questions might come sooner. And also, participants or our colleagues who are joining us virtually will be also asking, you drop your questions in the chat or be prepared to present your questions as well. I have a few in mind, however, I'm not going to go first, so I'm just saying.
Please let me know when it's ready for me to start the presentation. Can everyone hear me?
No, we're working on it. Can you just tell her in the microphone? Sure. Hi, Yana, we're working on your slides right now, okay?
Oh, I'm sharing on my end.
You're very, very faint. We're working on the volume. I just want to confirm that you do have control of your slides.
Yes. Yes,
Can you move them up and down?
Oh, wait, hold on. Can you see it's
Okay, good.
moving forward and back? Okay. Can you hear me, or is it my mic problem, or?
We're working on your volume. Thanks for your patience.
Oh, thank you for working on it.
All right, as we're waiting, let's think about this. What is one thing that is top of mind from any of the presentations today, except for your own? Oh, come on, y'all. Yeah. Mm-hmm. Mm-hmm. Yeah. Okay. If you want to stand up or if you want to come up here. If you just want to stand up and then respond to the question. If you could repeat the question, because I see that we have chairs for our panelists. However, we don't have mics for the Q&A part. So let's make an executive decision. Is everyone comfortable coming up here? Yep. Okay. And we'll do that once we get Yena's presentation up there. Yeah. Oh, we have one. Awesome.
I'll turn it on. I don't work here, but I saw it.
Great.
Okay.
All right. Okay. The question was, what is New York State Department of Health doing to improve data collection for race and ethnicity? So our team actually works on a toolkit to improve race and ethnicity data collection with specifically hospital facilities right now. Hopefully in the future, maybe with some community orgs and stuff. But the purpose of the toolkit is to provide different resources in either like written materials or trainings to address different levels of barriers that may be happening for accurate race and ethnicity data collection. Julia, if there's anything else you want to add?
Yeah, I just wanted to add, we have a base document that we created with different resources in addition to flyers and brochures for different audiences. So this includes like frontline staff, patient-facing materials, and also data specialist-facing materials. So it's been interesting working in this area, and there's much to do with race and ethnicity data collection improvement.
Does anybody else have any other questions that I could pass this to another panelist and put them on the spot with?
a small room, but yeah. I actually have a question for your team. So I found it really interesting the way New York State defines rural, like, what's considered rural. And the numbers you showed were very fascinating, I learned a lot. One question I have for you, and I'm not sure if you have the answer, but as there are lack of transportation, there's a language barrier, and then there are a bunch of other issues that this minority population is facing. What are some of the community stakeholders that are working with them right now? Are there religious institutions that are working, or they're nonprofits? I'm not sure if that's something you looked into, but I'm just trying to get a sense of what's the closest thing that they can reach out for if they're in need. So yeah, broad question. I don't know if you have an answer.
I'm going to ask you a question then.
Yes.
In terms of more of the increasing diversity side of it, or more of just the general world population?
I was interested in the refugee and immigrant population, those who are lacking the health support. So who would they reach out if they have to? Who would be their first contact, given their language barrier and lack of mobility and lack of resources? I don't know if that's something you guys looked into. But
Thank you for the question. What's your name? Farhana, thank you. So we didn't really get a chance to look into the specific community organizations. Our data was really just from OTDA, looking at the Refugee Services Provider Directory, and then going from there. But I know that directory includes health resources in addition to other social support systems. But it would be interesting maybe down the line to look into different community orgs in these surrounding areas.
I do know that with working with the Refugee Health Program, the provider network that they have sort of set up, they're obviously a resource throughout the state for refugees to access. And then New York State also has the Office of New Americans that does a lot of this work as well. And they support folks all across the state, not just refugees, but all new arrivals too. Yeah.
If I could just add, my name is Michelle. I work at Catholic Charities here in this area, and part of my work is I run a mobile outreach office to rural and remote communities in 10 counties. Catholic Charities is 14 counties in upstate New York, this area, Greater Capital Region and beyond. And one of the things that I keep thinking about from even the opening session and this session is that all folks that live in rural and remote communities could identify with the research I think that has been provided here today. People that we deal with, no matter what their background, are dealing with transportation issues and childcare issues and fear around mental health or mental health diagnosis or accessing healthcare. I mean, it's across the board very similar to the folks that I serve and my office serves on a regular basis. So just the similarities just keep coming up for me, and I do think that your work, or the folks that are working in rural and remote communities, how critical it really is, because there is such a need for funding in those areas and services in those areas. But to your question about service providers, Catholic Charities and other human service agencies are certainly ones that are on the front line in those needs. With the 1115 waiver coming down in New York State, that's another huge entry point, I think, for a lot of folks on or could be. And someone comes for a health-related issue, but then it's known that they might need help in other social determinants of health areas. If there are social service agencies who can help you with that, will be a big development when it comes to access.
Thank you for your comment, because I was thinking about some of the common themes, throughout the presentation so far. Language access is huge, right? So By training, I'm also a healthcare interpreter. And when I work with, and my language pairs that hold up in a court of law are Spanish, English, English, Spanish. You know, I think there also needs to be an education about empowering our communities about their right to access language access services. So our office did do a study by funding Capital District Latinos to do basically a climate assessment of the community's awareness of their right for quality language access services, which is separate from New York State language access law, right? And so it turned out that many of our communities, because this organization that is based here in the Capital Region is shouldering the lion's share of new arrivals, right? Even though we're a sanctuary city, the funding, as the co-founder said today in opening remarks, that, you know, the funding is sparse. And so when we did this, what we found, or what they found and reported, was that there isn't an awareness of the right to have quality language access services. As one individual reported, their response was, oh, this is what they're supposed to do? I thought they were being nice to me. And so this is information, right? Because healthcare in English is complex, English to English. And then we add that cultural and linguistic component to it, and it becomes extremely, extremely overwhelming. And so our office recently had a presentation given by Amanda regarding health literacy and plain language. And we gave examples of phrasing, something like, you know, for a GI, gastrointestinal patient who was told to eat, eat small, something like eat less food or something like that. It was like, are you really saying eat small meals? Because, you could have a peanut. I mean, is that what you're talking about, like small food? So, or signing a consent when somebody is their most vulnerable, right? So if it's an inpatient procedure and you have first case, you or your loved one may not be in that space to understand that jargon. So what can we do to support effective communication for our communities? And so empowering our communities regarding language access, this is what I'm hearing from the group. And please feel free to chime in, because this isn't the Wilma show, okay? Cultural awareness, as Jeanette was talking about, when we worked on the class standards, what was changed from the 2020 version to the 2013 version was the principal standard of health literacy for leadership, right? Because if we don't have leadership buy-in, then this is just a nice conversation, right? So that changed, and then opening it up to individuals and groups, and also other community-based organizations, because anyone who has been working with at the county level for social services, if you go to that WIC office, that's healthcare, right? And so what is that individual's right, regardless of documentation, to receive that effective communication, right? So that's the other thing I'm hearing about, that cultural awareness, and culture not specific to race and ethnicity, right? An example I use about culture is, who's ever worked the night shift? Anyone here ever work a night shift, 11P to 7A? Okay, who's with you? The rest of people who are working 11P to 7A, right? And sometimes it's like, hey, when did that policy go into place? Nobody told us, right? Because we're kind of like the forgotten group. And so that night shift is a culture, right? When working that shift, we figured out where to get lunch, because lunch is probably 3 a.m, and what's open around there. So that is another way that we can think about these cultural pieces. Oh, go ahead. Yeah.
Can you stay there? I need you to intermoderate for me for a second.
Sure.
Unmute her mic.
To unmute?
Ask her to unmute her mic and then talk for a little bit.
Oh,
Hi, would you unmute your mic and then talk a little bit to see if we can hear you?
yes. Can you hear me better now? Is it better?
Keep talking.
Okay. Mic testing. Is it better now?
All right, keep on going.
Keep
Go
going.
on. Keep going.
Keep going, yeah.
Hi, everyone. This is a bit awkward, but I hope you can hear me well soon. Is it better now? Still
No,
not?
not yet. Not yet. Go again.
Go again? Okay. Hi.
Yay!
Sorry.
I turn it over to you.
Oh, oh wow. Thank you so much for working on the volume so hard. And hello everyone. Sorry for not being there in person today. But my name is Yana Song and I'm a postdoctoral research fellow in the section for health equity of Department of Population Health at the NYU Grossman School of Medicine. Today, I am here to present my team's work on designing a culturally adapted digital solution called Our Child. And we developed this web-based app to address the childhood mental health disparities among Asian Americans in New York. And I just hearing from some of the questions, I guess there has been a lot of discussion that involves around like cultural adaptation and language access. So I'm very pleased to share my work, and I also feel very honored to share this work with you all, as May is the Mental Health Awareness Month, as well as the Asian American, Native Hawaiian, and Pacific Islander Heritage Month. Okay, to give you a brief background about the community, Chinese Americans are the largest Asian American subgroup in the US and in New York. Sunset Park in Brooklyn is also known as the Brooklyn's Chinatown, where our large population of recent Chinese American immigrants reside. Members of this community are characterized to come from a low socioeconomic status and have lower literacy levels, as well as limited English skills. As early childhood mental health and development is a critical time period that can shape the foundation of one's overall development, it is critical that they receive sufficient care from parents, reach their developmental milestones, and also receive appropriate services in timely manner if there is any signs of delays to reduce the risk of worsening of the symptoms. However, in low-resource, vulnerable communities, which often are communities of color and recent immigrants, young children from these families are at greater risk of mental health problems, and these families have limited access to evidence-based and in-language resources and care. Moreover, we found out that a large proportion of Chinese American patient population at the NYU Langone 7th Avenue Family Health Center in Sunset Park, with whom we are also partnering with for this project, are mainly monolingual in Chinese and have limited engagement and access to their electronic health record system called Epic's MyChart, and that is due to the limited language service it currently provides. So to address the needs of this community, the goal of this research project that we aim to design, build, and implement an integrated mHealth solution consisting of a bilingual web-based app, both in English and Chinese, and that is also connected to the Epic's MyChart, which is our electronic health record system, to increase access to early childhood mental wellness information and resources for families with young children ages between 2 to 6 years old living in Sunset Park, Brooklyn. So this project has two aims. One is to design, build, and pilot test the Our Child app. And then second is to implement and evaluate the app. So in this presentation, I'm mainly going to focus on the aim one, where I'm going to describe the co-design process of the culturally relevant and in-language digital solution. And we used a community-based approach to design this app. So in order to inform the development of the web-based app, we first review formative research data from and information from existing studies and programs programs that targeted Chinese American communities to learn about their needs. Additionally, we also collected our own data through interviews and focus groups with different community stakeholders and partners, and also we conducted user testing sessions with the parents to inform the design of the app. So based on the findings from the formative data collection has informed us about the needs of the community. So parents have concerns about their child's emotional, social, and behavioral health. There is also a custom among Chinese American parents who send their child back to China for a period of time for childcare, as they have a limited family support in the US. Parents also reported some conflicts related to parenting styles with their older generations, as a lot of Chinese American families live together intergenerationally, and grandparents or other family members often get involved in childcare. They also have limited access to in-language and evidence-based resources on parenting, childhood development, and mental health. And as I mentioned before, yeah, they have low literacy levels and lack of English skills, and that causes low use of the EHR My Chart, and they therefore also prefer apps and web-based apps or digital devices that's similar to Chinese apps. Based on the formative findings and applying the community-based participatory approach, we implement the community's needs into designing of the digital library, which contains culturally adapted evidence-based resources. And now I'm going to share more about the process with you, how we develop the content of the libraries. So the community expressed their needs that they want to know about accessing New York City's early childhood education services and programs, besides the information on early childhood development and mental health. Through the interviews and focus group, through the iterative process, we've identified 11 different domain areas that are relevant for early childhood development and mental wellness. And as you can see on the right side, here are the list of domains that we created each content into. Moreover, it's important to integrate Chinese cultural norms and values into content materials, such as addressing complex family dynamics and multi-generational households. So we adapted content centering around multi-generational families, and also like emphasizing on harmonious and hierarchical family relationships. Last but not least, as mentioned before, due to the language barriers and limited experience with MyChart patient portal, we developed the digital resources in both English and Chinese languages. And we made sure that each content piece contains simple and actionable steps and are in plain language, so no jargons. And we also developed the resources in different media types, as parents have reported they prefer videos, or they prefer less reading, or have no time to read the material, so they would rather listen. Therefore, we developed some of the materials in videos, infographics, and some articles with images. All the articles has images. And even by selecting the images, we took the consideration of the cultural relevance. As results, we developed more than 100 culturally adapted content materials for the digital library. So now that we have developed the content materials ready to go into the web-based app, we also had to develop the actual app itself, which will contain the library within it. Now I'm going to switch gears a little bit and share about the design process of the actual web-based app and the cultural adaptation process. So to apply a participatory and culturally centered design process, the development of the app required iterative and bidirectional communication with different groups, including the software development vendor, healthcare providers, and also community and patient groups, which are mostly like parents. We hold regular meetings with the vendors to discuss the design of the app. and also interviewed and conducted focus groups with the providers and community groups to receive their feedback. We also conducted user testing sessions with the patient groups, as they will be the ones who is going to use the actual app. We had some learning curves, and it was not easy, and I'm going to share. And so this is what the first draft of the vendor design looked like initially. And we might think, it looks fine. It looks very clean, simple, and it looks like a clinical app that's developed by NYU Langone with the purple sign. However, it certainly was not culturally tailored. Considering the app is for the parents of young children, considering the cultural differences and barriers they uniquely face, the initial design was certainly not the way what the community wanted or they were familiar with. So we went back to the community and asked about their opinions, and we brought the feedback back to the vendor for another round of redesign of the interface. So this is what the draft looked like after redesign. So it's like the second draft. After we got more feedback and suggestions from the community. It got a little better, but then, and more visually engaging as well, but we thought we're still not quite there yet. Although we've intentionally selected a vendor with experience working with like international agencies and have experience developing foreign apps, it was still a bit hard to convey the community's needs to the vendor. At that time, we actually found this article that you see on this screen that highlights the difference specifically between the Chinese and English apps. So, and it helped us tremendously on redesigning the app, and also so that it's more centering around the community and culture. This article highlighted that there is a difference in using the white space, use of colors, animal symbolism, and typography. So to explain the difference between some of the differences between the Chinese and English apps. So Chinese apps focus more on the functionality rather than use of space. So the apps try to contain as much information as possible in one page, and they use different colors, vibrant colors, rather than like on the right side, where we are more like used to see, where there's a lot of like white space focusing on simplicity, like more in a lot of the English apps. Moreover, Chinese apps use a lot of like animal symbolism. So for example, the deer symbolizes longevity in Chinese culture. So this health app uses a deer character to symbolize that this app is for health, and they often include lots of like colorful elements in it. Also, typography is something that should be selected carefully, as the space differs. That the space that each character takes is different from how much like an English word or letter takes. So we took all of that into our consideration as we were developing our app and in our app design. So we have adapted them into our own design. So we made sure in our design process, we made sure that the visual representation and design includes familiar elements of Chinese apps and websites, for instance, recognition and easier usability. We also made sure that colorful and childlike elements are included. So for example, as you can see on the top part, we included Chinese animal zodiac signs that match with the child's birth year to make it more engaging for the parents. And also down below, it shows like the evolution of the quiz website, a quiz side of the app, where we included more icons that's relevant to the specific screener. so that parents can instantly recognize what the screener is for. And we also carefully consider about the typography so that it can support Chinese characters. So this is how it looked before adaptation, and this is what it looks like in the current phase after adaptation, centering around community and culture. So we completed aim 1 of the study, which is we completed the developing of the app. Currently, right now, we are collecting data of 120 parents and child diets from 7th Avenue Family Health Center and NYU Langone to see the implementation and evaluate the use of the app for 6 months longitudinal study. This study implies that the user-centered and culturally tailored design approach is informing the development of a promising web-based app, and that it will address a health disparity gap by facilitating access to reliable resources for the Chinese American parents and also foster parent-provider communications. Thank you for listening. And if you have any questions, please let me know.
Thank you. Don't go away. Don't go away. All right, so I'm looking at the time and I'm thinking, you know, from our presenters, let's give everyone a round of applause first. And since, you know, this is a question and answer period, so if we have anyone that is joining us remotely, please feel free to drop your questions in your chat, other than the ones about whether or not this is working. Okay, we don't need to look at that. All right. In the interim, what I'd like to do is give the floor to our presenters and let's see if there's any questions from the audience first. All right, let's see. Yes, sir.
Yes, my name is Alberto Contreras.
Mhm.
Good afternoon, thanks. Is it on? Okay. Thank you. My name is Heriberto Contreras. I'm from Westchester County. As the data showed, the amount of immigrants increasing, the amount of providers decreasing, the amount of languages spoken in New York State increasing as well. The change in paradigm that is required for our communities to consume the healthcare products and the social determinants of health impairing that access. One of the things that I've noticed that there's been very little change or no change at all in policy is in the, I guess in the pharmaceutical sector in terms of dispensing. And there is a grave, I guess, need for that to change. We have technology to assist in providing care for many of the different patients in their own language. But yet again, when we dispense medication that is so critical in terms of dose, in terms of quantity, and in terms of timing, that is so critical for them to ingest. And yet again, it's only done in English, oftentimes causing severe accidents or the lack of following up to better themselves. I'm not sure whether anybody here in the group has any comment or update in terms of any policy suggestion or change in that. I've had families in my neighborhood who oftentimes read the word dose as referring in Spanish to 12 and almost ingested 12 pills. And also teaspoon. What's a teaspoon for a Spanish speaker? Is it little spoon, big spoon, soup spoon, etc.? So that's one. And second of all, the immigrants, our population, and I consider myself one, we are, many of us are recent arrivals, others have been here for a little longer, and others have been here for 1 or 2 generations. And yet again, we access healthcare in many different ways. So while rural areas have access or limitations in transportation, more urban areas have, long waits for appointments, three months for provider appointments. And so I would like to hear a little bit more as to what's being done in terms of that to provide a little more access. Thank you.
Sure. So what I can say is New York State does have a Safe RX law that was passed between 2012 and 2013. We worked on that legislation to ensure that chain pharmacies, which is, the mom and pops, I think the law states like 8 or less, because they figure those pharmacies that are in our communities would have already addressed the language access needs. However, the Safe RX requires that the chain pharmacies, which I believe are more than 8 or something like 10, and you may have more of an awareness, that would include the Duane Reads, the Walgreens, the CVS's, the Rite Aids, to ensure that they provide language access assistance at the time of dispensing those meds. And so if you see, there should be, it's called Point to My Language, and there should be signs at point of dispensing that are in public view so that the information is provided in the language that the individual points to and requests. So that is mandated. That pharmacy goes through state ed, because that's where pharmacy regs sit. And so if you're not seeing it in a CVS, because I myself have, talked to, the pharmacist at the time when I observed something and I said, you do have a Safe RX law. And they're like, well, and I'm like, no. And you're also asking a minor, not a child, you're also asking a minor to interpret. So he's like, okay, we'll get the phone. So, let's be in compliance. So that is in place for chain pharmacies. So your CVS's, your Rite Aid, your Duane Reads, your, Walgreens, that is in place there. And that goes back to the point that individuals have the right to the provision of language access services. Yeah, and you may have something also to add. Yes,
I wanted to just quickly,
You want to give her the mic?
Thank you. And thank you for, feeding us that information, because I myself, as a healthcare receiver, I've never seen that. And although English is not my first language, but I understand, speak, and read it very well. So even, I guess, the importance is health literacy. For these policies to be implemented, organizational health literacy is something that is really important to be aware of, and to have it, have implementation signs, to have it actually hold healthcare organizations responsible for, first making their own staff members and organizational members that is something that they would probably want to aspire to have, and then also have policies in place. But also, individual health literacy at the individual level is important. Oftentimes, what happens, especially in the US, and my data might be a bit outdated, but at a few years back, it was almost like 90% of the US, people in the US didn't have the required level of health literacy. So it's like people like you and me who do, and then we wouldn't understand, but also Americans were not reading at the required level that they would need to have, like 5th, 6th, 7th, 8th grade level, so that they can actually understand. So with health literacy, what you also point out, it's numeracy literacy. So it's the math, like how many times do I have to? So most of us, after we get out of the doctor's office, we just forget, what they told us. So there are some communication strategies in place that individual doctors could utilize, which is like the teach back method. So as they're providing care for the patients, they could ask them, can you please repeat back what you understood? So, then you have, so that's why you need to have that organizational policies in place because oftentimes we know that there are not,
enough resources or funding to actually put these things in place. So I just like wanted to give kudos to you. This is very, very important because with health literacy, you just not just reading and writing, you need numeracy literacy, you need scientific literacy, because it's also information that is feeding off to us like as jargon, medical information and whatnot. So it's quite complex. So I just wanted to, have my 2 cents out there. Thank you.
I was just gonna say, is there a movement to, I have to pick up the mic, is there a movement to expand this? Because so many people who may be marginalized communities are in a little corner pharmacy, they're, not able to get to some of the big chain pharmacies, and so, that needing to be a part of a medication dispensing in general. I'm also concerned because it seems like that's not happening at the doctor's level. Too many people are getting prescriptions, they're just getting sent in electronically through a system by the doctor, and it's not even discussed with patients. And I find that myself, but it's not discussed well. People get to the pharmacy and they expect the pharmacies to do it when their own medical doctors and nurses aren't doing it before the patients even leave and should have the opportunity to ask those questions. I worked with breast cancer patients, and one of the things that shocked me was that so many of people who really had very little English literacy and were not getting the interpretation they needed thought the ports that were being put in their chest were pacemakers. They would go home and talk to somebody in their community. They would say, "Oh, you must have heart problems," and then we'd find out they were withdrawing from cancer treatment because they thought they had a heart problem as well. And there was this complete confusion about what was happening. And getting interpreters in. So we were getting native speakers in, not on phone, not on but native speakers in to go with patients into the room, and there's a lot of doctors that like either, even if the patients wanted them, but that's beside the point. The issue though is still what is happening with doctors being required, not just sending electronic scripts, but talking to people about their patients about them and making sure that patients can ask questions. And also that, again, in all pharmacies, or, it's deadly. People are thinking they take 12 pills instead of 1, that's a deadly situation.
Yeah, or 11 for once, right? And it's once. Jeanette, do you have anything to maybe add about, how the, maybe some recommendations or thoughts about the importance of the class standards infusion?
I guess some of what is truly disheartening is that we've been having this conversation for a very long time.
Exactly.
So this notion of talking about the standards and culture and language, I've been doing these talks for like 20 years. And if anything, I think the issue's gotten worse. And so it's when we talk about the standard, there's so many more languages now in this country than there ever was before.
The doctors have so much less time, nobody cares.
Yeah, less time. So our research team has worked with local hospitals, and one of the, they give me such
Excuse me?
examples. So for
Please use the mic. I was just told that if we don't use the mic, the recording isn't picking it up. Sorry.
working with a local hospital, such a poignant example. So the example is someone whose language doesn't match the language of anyone who's just undergone surgery. And they wake up at 2 or 3 in the morning. And usually what a physician will do is try to assess their level of pain or discomfort. And there's nobody around, and there's no one to ask the question of that patient at 2 in the morning. That this is a real serious problem that they have. And this was recently. So people think, well, it's in the order of prescription of this, but just someone coming out of surgery, there's no one to talk to. There's no one to translate what is happening with that individual. So what amazes me to listen to all of this, I heard all of this 20 years ago. We are still here, and worse, because there's more individuals, there's more. Now, the other piece of this too is training. There aren't enough people being trained who come from, have these backgrounds. So just the educational piece is contributing to our problem many times over. I don't know if it's a notion of just not having access to education, individuals choosing other routes and not, being trained. For example, I said I was a cognitive psychologist, so I'm a cognitive scientist in psychology. Still, in terms of people like me who are Latina, who are minority, we're still under 1% in that field. And I've been in the field almost 40 years now. So we're just something in education that we're not progressing, and something has to change in that way. But that's what strikes me, is that if anything, now we need, I mean, these class standards, so many people haven't heard about any of this, and so many organizations, here in New York State, and all the places that we go. And the cultural piece is so important too. So one of the things, culture is multiple, so it's not just where you come from and so on, but you're right, people's experiences. So in therapy and so on, people wanting therapists who were also veterans, or were also in the Army, and the intersectionality. So that's another paper that we have written about, that now it's not simply, I'm Asian, you're Asian, but I'm Asian and I'm this and I'm this and I'm this and I'm this. Can you find someone who represents all? So the intersectionality now is a bigger thing to think about too. But we're going backwards. I guess I'm not feeling palpably that we're making the right progress here in New York. So this is a huge challenge still, I think.
Do we have someone on the remotely who has a question?
Yes, I don't
I
really.
see a hand up.
Hi there.
Yes, sir.
Can you hear me?
We can't hear the gentleman.
Hi there.
Oh, can we?
Hi there. I'm going to try again. Can you hear me?
Oh, there we go. Yes, now we can. Thank you.
Super. Hi there. My name is Dr. Van Slypen. I am partnered with Mr. Halal, who presented earlier. You know, we did the social work perspective, and I think that what is very interesting is that, you know, Mr. Halal has been looking at ideologies and the way that ideologies manage a situation. And I keep hearing these interventions, these very specific interventions, these very specific needs for language, for training, for presence, for bodies. But I'm not hearing where the money is coming from. And the money is driven by the policy and driven by the ideologies. So how do we actually move towards a space where we're actually able to see people who are marginalized in this way, regardless of where they're from? Well, I mean, the previous speaker was discussing intersectionality. I think that there's no one who would agree more with intersectionality and the very diverse needs that this community represents. However, the money is not being allocated, and the money is being allocated according to ideological positions. So how do we move towards a space where, at the very least, and in the most crass way, we can actually honestly say that these folks are contributing significantly to the society and therefore need to be resourced?
Hello. Okay, awesome. I actually really appreciate this question. So I am actually not a researcher, I'm a lawyer, and I do our advocacy and policy work at the Asian American Federation. And I think the question speaks to like gaps in resources. And one of the things that I wanted to just raise for the folks in this room is that although it didn't succeed, there are community-based organizations and collaborations among folks organizing around with communities of color to address funding issues. And so, for example, in this sort of we were in Albany, and in this year's budget fight, a coalition of groups that include the Asian American Federation, which represents 70 Asian American groups around the city, the Hispanic Federation, which of course represents hundreds of Latinx groups, the Urban League, and the New York Immigration Coalition, proposed similar, like a first of its kind communities of color mental health initiative to try to get resources to the communities for all the things that we mentioned, right? Like language access, culturally appropriate resources, changing the field so that the providers look like us and understand our cultural context. This was the first year that we tried it, and it like didn't go anywhere. But I guess one of the things that I'm hopeful for is that over time that there's more organizing so that the community-based organizations, the folks that have relevance and reputations and sort of currency in those communities can be better resourced. And so I think not only from a policy perspective, but from sort of a legislative perspective, it's also making our legislators aware that these issues are important. And then with respect to whether it be mental health or other kinds of healthcare, like the kind of destigmatization that happens around these issues, because it is one thing to create the pipeline, but it's another thing to be like, okay, from our legislative leaders to our community-based organizations to other sort of leaders in our communities, that it's okay to get help, that there are resources available for you in language. And yeah, that like there's actually an investment behind it that isn't just going to be like a one-time thing.
Thank you. Thank you for that response and that comment. Additional questions? We're close to wrapping up. Yes.
Question for you. I've been meaning to ask you. Thank you for informative presentation. So you did as a final product the web-based directory, right? So just this health literacy part, I guess like doubled down on me. Would you say that that is not accessible by everyone? Because you need to have digital literacy, and we know that, yes, so what could be a possible solution where folks, you know, that suffer from lack of that digital literacy, what could be an alternative solution for them to have access to such a useful directory?
Yeah, I mean, here's what I would say. I think the larger structural problem is a lack of healthcare literacy, or digital literacy generally. And so one of the things that we talk about at the Asian American Federation is, so for example, how are folks getting information about really anything that's going on in the community? And that looks different, let's say, for Mandarin and Cantonese speaking communities versus Korean communities. And so what I think one of the things that the mental health directory offers is sort of a drop-down menu of folks that speak different languages. That said, I think, this is just sort of me thinking about it, would be like a way to make it more accessible would be, again, if you resourced case managers and people within the community and had sort of people who are able to help folks navigate that process, similar to the presentation that was done by the person from NYU. I think it's about making the cultural adaptations that make it accessible for folks, and then destigmatizing the resources. So I think there's a larger investment of resources in the allocation and funds that's a problem, and whether it be digital literacy, because I think there's a ton of hosts of issues and challenges with that, because there's also privacy issues. So I think if you're talking about low-income communities of color and immigrants, there might be one cell phone for the entire family. So, I think that there's many stages under which there are healthcare barriers for our communities, and I think, like this is our first shot at trying to create an access point, but I think that there are many levels under which certainly there's divides between newer migrants and older folks, and then of course the fluency for which many young people access resources online. So I think things are changing, but I think it's certainly a long road ahead.
All right, I am looking at the time. I don't want to discourage questions. And Yana, is there anything you'd like to add before we wrap up? Anything you'd like to share, last words, anything like this? Give me a thumbs up if you're good. All right. Well, thank you, everyone. This has been a wonderful event, presentation, sharing of information from so many experts. Thank you very much for joining today, participating. And as our colleague just said, this is, maybe one of the firsts with this type of conversation. So let's continue the discussion. According to the agenda, we do have closing remarks at about 4:45. And so I think we return back to the ballroom is my understanding. All right, thank you, everyone. Great job.